Thanks for Paediatric Emergencies organisers for asking me to speak about this. I'm hoping I haven't bitten off more than I can chew by trying to cover this subject, but we'll soon find out. So I'm going to talk about the deteriorating child with complex needs. The reason why I've selected this subject to talk about, I don't believe it's been covered in Paediatric Emergencies previously, but it is a very frequent referral to paediatric intensive care. And the children that I'm going to talk about are sort of an overrepresented population within acute pediatrics and in high dependency and critical care settings as a proportion of the total population of children. We'll go through a number of things, but we're going to focus really on respiratory deterioration, as again, it's probably the most common thing that we're contacted about in PICU regarding this kind of patient population. So the medically complex pediatric patient, or the various terminology that's used about these patients, some often where we work, these patients are summarized as complex neurodisability. And really what we're trying to describe is children that have very complex medical needs and require sort of significant assistance with multiple aspects of their daily living. So, and usually due to a chronic, often progressive underlying condition. And the underlying condition itself might be of genetic etiology, maybe metabolic, maybe chromosomal, maybe neuromuscular, or maybe due to an acquired brain injury, i.e. cerebral palsy, a traumatic brain injury, or issues related to prematurity or previous infection. And in some cases, we have a child who has some very complex medical conditions but doesn't actually have a diagnosis because our genetic tests perhaps haven't been able to pinpoint the precise abnormality that underlies what's going on with them. As such, as part of sort of daily life for these patients, they may have significant limitations to mobility, to feeding, to communication. They may have complex epilepsy, may have complex tone abnormalities such as reduced or increased tone. They may have kyphoscoliosis and other skeletal problems. They may have various degrees of intellectual impairment. They may have an impaired swallow and feeding difficulties with associated severe nutritional challenges. Talk about technology-dependent children now. So some of these children may require non-invasive ventilation. They may require tracheostomy and ventilation. They may require feeding devices beyond your nasogastric tube. Multiple systems might be involved in their underlying condition. So you may have cardiac and renal abnormalities, as well as sort of the neurological and functional limitations that these children present with. And as such, they may also have things like VP shunts and VNS stimulators in situ. And the patients often require multi-specialist care and have a long list of medications for symptom management and for therapeutic management of their conditions. So often a very, very difficult patient to get to grips with. And I'm sure when I'm talking about this, everyone will know patient or patients like this that they've encountered in everyday work. And indeed, they may encounter frequently the same patients in everyday life or everyday work when covering acute pediatrics, either in the emergency department or in the pediatric setting. In terms of I said I'm going to focus on respiratory deterioration in these children. Now, obviously, these children can have issues that any other kids will get, i.e. septic shock. They can be involved in car accidents. They can get kidney infections. Other things that may be more specific to these children might be things like refractory epilepsy and dystonic crises, usually managed with specialist input as well as sort of APLS algorithms. So I'm going to focus more on the condition that really probably limits these children's lives in most circumstances and presents in the most common presentation to our setting, and that would be sort of respiratory failure. These children tend to be vulnerable to chronic progressive respiratory failure for a number of reasons. You've got the aspiration risk, which can be chronic, so there could be chronic small aspirations and then acute larger aspirations that result in sort of a more acute deterioration. They may have increased oropharyngeal secretions alongside an impaired cough and impaired airway clearance, which again may be exacerbated by poor posture, by kyphoscoliosis. And then the kyphoscoliosis in itself can result in restriction to the ability of the lungs to inflate and reduced lung volumes. Additionally, they may be colonized with sort of atypical organisms and hospital-acquired organisms and things like Pseudomonas and resistant organisms that they've picked up through various kind of admissions to the hospital. And again, going along with this, there may be chronic atelectasis and consolidation, resulting in a kind of a reduced respiratory reserve. And this can, again, be part of all of these factors I've talked about, the kyphoscoliosis, the poor tone. And then in addition to this, again, must acknowledge there's potential for nutritional deficiency, which increases the risk of infection and reduces the ability to recover from infection. And then there may be respiratory muscle weakness, alongside the low tones. It means there's a limited capacity to cope when there's an acute reduction in that reduced baseline respiratory reserve. So if you get a sick patient or a sick patient with complex needs, thinking about how to assess them, because we talked about how complicated this is, how many distracting features there is, how many things you have to consider. So how would you approach assessing and investigating these children when they come to your attention? So use your standard ABCD assessment. You can't go wrong with it, and it applies to all children. And use your objective and subjective kind of measures of how sick you think the child looks. I would make special attention to note stridor and stutter in these children. So stridor may hint that potentially if these children have been, say, had a long course in the neonatal unit as infants or had many presentations to PICU requiring recurrent invasive ventilation, there may be subglottic stenosis in the background that hasn't necessarily been diagnosed yet. Stutter may indicate low airway tone and floppy oropharyngeal kind of tissues that might be making things worse. For me, I would consider pallor and reduced consciousness an indication that this child probably has a decompensated respiratory acidemia. Not necessarily, but that would make me suspicious of that. And one thing to bear in mind with the reduced consciousness is to review recent medication changes and explore the history for any recent seizures or changes in seizure patterns. What you may be kind of seeing as a respiratory deterioration may actually be secondary to the reduction in consciousness level, as opposed to the consciousness level being reduced in response to a respiratory deterioration. So again, kind of summarizing the signs of ongoing deterioration would be an increasing heart rate, increasing respiratory rate, reduced GCS, and an increased requirement for respiratory support. So depending on what your child's on, if they may need more oxygen, they may need more pressure on their emergency settings on their home ventilator. Just one caveat just to bear in mind is with the child with sort of neuromuscular conditions, such as muscular dystrophy, they may not mount an increased work of breathing response, and a more ominous sign actually may be that their breathing becomes more shallow, starts to slow down as they can't kind of keep up, they become tired more quickly. In terms of investigations, I would get a chest x-ray, get secretions for virology and ONS, and check a blood gas. And I think it's very important here to acknowledge the role of the parents and the carers with these patients. So as we know, all parents know their children best, but the parents of these children usually have been through a lot of previous encounters with healthcare, both in outpatients, in inpatients, maybe in the intensive care setting, whether it's neonatal intensive care, whether it's pediatric intensive care, and they generally have more medical knowledge than the general population, and will actually usually have a lot of clinical insight into their child's specific challenges and their child's specific needs. They may know that their child is colonized with Pseudomonas. They may know that their child responds well to PEEP. They may know that their child doesn't tolerate, a high CO2, and they may know what their child's normal gas looks like. So it's worth speaking to them and finding out what their specific concerns are, what things they look out for when their child's sick, and what things work to make them better. I think it's very important to look at previous investigations and previous admissions. So look at the chest X-ray just to see, is this the changes that you're seeing, are they chronic or are they new? Look to see, is there a progressive loss of lung volume that indicates this is either a progressive change or is there something more acute like a new consolidation or a pneumonia? And look at the previous sensitivities for any organisms that this child may have grown. So rather than starting your bog standard kind of community acquired pneumonia antibiotics that you do in your unit, I would probably go with starting an antibiotic that would give coverage for those common organisms, but also cover the organisms that this child has previously grown. And I would do that in conjunction probably with speaking to the respiratory team and the infectious diseases team, just to guide management. So how to manage an acute respiratory deterioration, or how I would approach this. So I think communication is absolutely key to this. And that's communication with the specialists that are involved in this patient's care and know them well, and also the parents and the carers of the child, as stated. You should, and it will go, leaving aside the kind of the respiratory function. If you do have refractory seizures, dystonia, that's very much a specialist issue and to seek specialist advice for. But focusing on the respiratory deterioration for now, one thing to acknowledge is that these children are often receiving sort of what amounts to de facto kind of high dependency care at home from their parents and their carers. They may have long-term respiratory support. Their parents may be doing very frequent physio at home, very frequent repositioning. And so it's worthwhile checking with these parents, what things they've been doing and what things you need to continue doing that they feel work for their child. Some of the things that they're doing, actually, some of our pediatric wards kind of are almost, hesitant to replicate because it meets sort of high dependency standards for care. But that might be what you have to do to kind of keep these children on an even keel. As I said, it's important to review the previous culture results to guide your antibiotic therapy to make sure that you're getting appropriate cover. But I think the major focus with these children when they're having acute respiratory problems is to really assist with airway clearance. So I think this has to be proactive management. I think if you get a child in who has very complex needs, the sort of child we're talking about, the sort of child that we all know, if we kind of do the first things, i.e. give oxygen, give fluids, give antibiotics, and then we just let them lie in bed and kind of work away, I think we're setting them up to fail. So I would advocate that we make sure that they have good posture in the bed, and that means frequently changing their posture. If they start to slide down and they start to lie down on their back, I would advocate getting their own equipment in from home if possible. So the seats and chairs and things that they use at home are fitted for them and ideal kind of to improve their posture. And I often would say to parents, bring these things in so we can set the child up and make sure that we're maximizing the lung volumes. I think chest physio is important. Sometimes people are hesitant if a child looks like they're tiring and they're worried about chest physio making things worse. I think you really have to kind of balance that up with letting them kind of struggle on and potentially de-recruiting, plugging off a major airway and becoming very sick very quickly. So I would see chest physio and good kind of coordination between the medical team and the physio team as vital in managing these patients. I feel I'm very lucky where I work. We have an excellent physio team, and I think that relationship we have in managing these patients is really, really important. So the other things sort of in terms of airway clearance would be, you think about mucolytics, things like hypertonic saline, things like DNAs, even just normal saline nebulized, to try and loosen up thicker secretions. I would look at kind of any anticholinergic drugs that the patient might be on, such as hyoscine patches or glycopyrrodium. Often these are started to reduce oropharyngeal secretions. But in some cases, if the child has an acute infection, these can make lower airway secretions harder to shift, harder to cough out, harder to get out for the patient. So balance up the use of those medications for upper airway secretions versus the clearance of lower airway secretions. And I think it's important to kind of discuss that with the physios. I would consider early anesthetic review for these patients if you're worried about them. The reason being so that the anesthetic team can plan accordingly for a potentially difficult airway and be able to see the patient, have time to review previous intubation episodes and look at previous issues there might have been when respiratory support was escalated previously. I would tend to advocate in the early period until they're kind of stabilizing out, holding feeds, but I would continue to give critical enteral medications such as anti-epileptic drugs, antidystonic medications where you don't have another route to give these or you don't want to change things too much. Other things I would consider, if there's strong evidence of reduced upper airway tone, I think using a nasopharyngeal airway might help things. It gives an avenue to suction, and also if the patient's drowsier than normal, it might overcome some kind of reduced airway tone. And I would also I would suggest that you should address any other issues with the patient that might impact their respiratory status. So treat any pain that they might have, and treat constipation. Constipation is a major thing with these patients when they become less mobile, when they're more kind of in bed, and when they're just generally unwell, their gut might slow down. So that can really impact on things. They might make them vomit more, make them more uncomfortable. So address that. And also, I think treating fever can be important, because when children have fever, they often look a lot worse. They can often feel a lot worse. It can knock them off a bit. So I would suggest that treating fever in these children is an important thing to do too, and weigh that up. Often you'll have a patient who the call that we'll get will be, you have a patient who comes in, is a bit unwell, stabilizes out, they're being managed on the ward, and then they have a very sudden, very acute deterioration. Usually I would say that's a mechanical issue, generally mucus plugging of a main bronchus that's happened just if they haven't been clearing their airways very well, and it's just taken out a big part of their already reduced lung reserve very quickly. And my advice again would be the same: is try your airway clearance measures, try your chest physio, update the X-ray, be prepared to escalate the respiratory support substantially. And often this can be kind of turned around, quite, even if it looks quite hopeless. You know, your head looks like you're heading for intubation. You can turn this around with good physio, using nebulized mucolytics, repositioning, and sometimes even bagging for a short period with high PEEP through an anesthetic circuit. So just refer to quickly to a couple of cases that we've managed recently, just to highlight the X-rays and the things that you can turn some of these situations around. This is a patient who presented recently who has a chromosomal abnormality that results in global developmental delay, impaired tone, aspiration, impaired swallow aspiration risk. They're peg fed. They came to our attention. They had basically a history of a recent viral upper respiratory tract infection that progressed to increased work of breathing. They were on home non-invasive ventilator, and they were requiring more oxygen through that, and unfortunately had no emergency settings set up on the ventilator, so they came into hospital kind of looking in a bad way. So SATs in the 70s, working very hard, lots of sounds in the chest, and looking very much like they were heading for intubation. You can see, looking at that spine, looking at those low lung volumes, it's not an inspiring chest X-ray to look at, and the associated risks with intubation were substantial. So we admitted this child, we got good chest physio, increased their NIV settings, giving them a fairly high PEEP of 10 and putting their pressure support up to 8, so they're getting peak pressure of 18. Got them into their own chair at home that they use for sitting out, and a day later would really maximize the lung volumes, and this child stabilized out in this management and was able to go back to the ward and wean their respiratory support slowly. Again, this is another child who presented more acutely this is a child with a muscular dystrophy condition, again severe scoliosis and reduced lung volumes, presented with a very abrupt aspiration. You can see they completely lost the volume in that right side, a whiteout of the right lung. Very, very precarious child, requiring lots and lots of oxygen when they came in, very close to being intubated. The parents were very knowledgeable and knew the risks of intubation for their child, knew the risks of prolonged mechanical ventilation, so wanted us to try and turn this child around without doing any of those things. I agreed. I wanted to try the same thing. So we tried physio, we escalated NIV settings again, used a high PEEP, used a higher pressure support, did some bagging, and at one point I thought things weren't going to turn around, and I went to the parents and I said, look, I think we're going to have to intubate. The blood gas showed a decompensated sort of hypercapnic respiratory failure in addition to the hypoxemia. And the parents said, would you just give it one more go with physio and see how we go, because they really wanted to try and stay off a ventilator. We did that. One of our excellent physios in PICU really worked with the child. We got a lot of stuff up, and you can see the repeat X-ray sort of a few hours later. The child turned around completely, woke up, started shouting at us, wanted to take the NIV mask off, and really a startling for me, it was really startling demonstration of what you can do just by maybe giving the child a chance, not jumping in too soon with mechanical ventilation and doing the airway clearance. And the thing is, even if you have to proceed to intubation, all those measures will make things easier for you after you've intubated the child. Things to consider if you have to intubate these children. Sometimes these decisions are easy. So if they've stopped breathing, If they're in terrible shape and needing lots of oxygen and really things are very precarious, you just have to go ahead and intubate. But if it's less clear, if they're struggling, but they might be coping periodically, your threshold to intervene may be higher than sort of other children. Um, you should, I would advocate discussing with your regional PICU and respiratory service fairly sharpish if you think this child might be heading for intubation. And I think it's important to counsel the parents on the risks. And you might be able to contextualize these risks for the parents by speaking to those specialist teams. So mechanical ventilation is injurious to the lungs, and particularly if you have to use high pressures required. I would counsel parents on this all the time if I'm think one of these patients is heading for intubation. And I would say with these patients have in this setting with an acute deterioration, they'll have both obstructive and restrictive lung disease due to the kyphoscoliosis and sort of the mucus plugging. So you potentially will require very high mechanical invasive ventilation pressures to try and open these lungs up. In addition to that, it's very uncomfortable to be invasively ventilated, so we'll have to sedate them. We may have to muscle relax them. And that can lead to deconditioning these children and a loss of muscle strength, and then it becomes very difficult to liberalize from the ventilator, and that is a consideration, and that's why maybe you have a higher threshold. You maybe tolerate higher oxygen requirement, higher non-invasive pressures than you normally would, and sit on a blood gas, accept slightly lower sats, just because you want to give them time to see if you can recover. If you know you're heading for intubation or you think it's a strong possibility, plan for a challenging airway. So look at if there's any dysmorphia. Consider the sort of the anatomical distortion due to any kyphoscoliosis that might mean that the trachea is in an unusual position. And think about the reduced FRC, the reduced functional residual capacity for these patients. It'll be chronic, but there'll also be an acute element to the chest infection. So they won't give you a lot of time, and you are starting from a difficult circumstance, usually with a high oxygen requirement at baseline. And then also consider any congenital cardiac disease if it's present and what that does to your kind of hemodynamics. Anticipate that when you intubate and ventilate, you're going to have a lot of difficulty oxygenating and ventilating in the early stages. As I say, you'll have restrictive and obstructive lung disease. There'll be very, very challenging pathophysiology to deal with. Be prepared for more chest physio, for more repositioning, for lots of suctioning. Make sure your endotracheal tube is in the right place as soon as possible. So get the chest x-ray done. Be prepared to ventilate with high PEEP. So, and that sometimes be as high as your patient will tolerate hemodynamically. So you could be talking about a PEEP of 10 centimeters of water, 12 centimeters of water, 14 centimeters of water if you're having to open up a very plugged off small lung. Tolerate, a permissive hypoxemia, so tolerate SATs over 88% and tolerate permissive hypercapnia, being satisfied with a pH over 7.2. So in some way trying to spare those kind of high invasive mechanical ventilator pressures to avoid damaging the lungs unnecessarily, and also avoid trying to minimize or reduce the risk of evolving ARDS, which is a real problem in this patient population also. This subject could be, obviously, I'm going to deal with this very quickly, like I've dealt with this whole subject very quickly, this whole massive subject. This one could be the subject of a whole day's worth of talks on its own, and it's a massive, massive challenge in pediatric intensive care and acute pediatrics. We'll talk just a little bit about decisions and ethics and escalation of care. I think it's important to try and have these discussions outside of an emergency if possible. It's very difficult to have a discussion about the risks and benefits of intubation in a patient who's about to have a respiratory arrest or who's really, really unstable. And in which case, if you're in an emergency and there's an absence of an agreed ACP with the parents, you just go ahead and save their life. And even if there is an agreed ACP, if the parents tell you they just want you just to keep their child alive, that's what you just go ahead and do. And you do that thing in that circumstance. It is still important in those circumstances to counsel on the risks of intubation, as we've talked about. What I would counsel with parents, and I think it's important to be sensitive, but it's also important to be honest. I would be honest with parents, and I would say that my concern with intubation here would be that we're starting with very low lung reserves. This process may, in all seriousness, may kill your child. We may not be able to intubate them very quickly. We may struggle to ventilate them. When we lose their negative pressure respiratory drive, we may not be able to replicate their ability to breathe with positive pressure, either via mask or via tube. And things may get worse when we do this. I would talk about the difficulties of being sedated, being muscle relaxed, trying to liberate from the ventilator. And that's not to put the parents off or scare them or anything like that, but it's to be honest with the risks. It's to be honest with what we're trying to achieve, and it's to have an honest conversation if we all make sure we all agree that this is the right thing to do. In circumstances, sort of in PICU, or where there's a child who's sort of recurrently presenting the PICU and having lots of episodes where we think that the situation's become futile, you need a team agreement on that where you're talking about futility. You need to talk to the specialist teams involved, the people that know the child. And that just can't happen kind of in an emergency scenario. So it is good to address these things. If the child comes to hospital with a deterioration, I think it is good practice to address these things before they deteriorate, hoping that you can avoid the deterioration with all the things we've talked about, but acknowledging that sometimes it's out of our hands and it will get worse no matter what we do. And again, I take an honest approach with families. If I believe that intubation and ventilation won't work, if I think it's the wrong thing to do for the child, I will say so. I will try to reduce the burden. The parents do essentially have the final say in what happens outside of kind of legal confrontations and things we don't want to get into. But if there's a kind of a consensus in the MDT and specialist teams that invasive mechanical ventilation isn't in this child's interest, I will say that to the parents. I will say that I would regret intubating a child, potentially them dying during the process, potentially dying during on a mechanical ventilator, when the other option is to prioritize their comfort, prioritize their time with families and relatives, and given their care back to the people who've looked after them in everyday life. I don't personally talk about quality of life in these cases. We see these children at their absolute worst. Often they're feeling terrible, they're not very interactive, they look sick. We make assumptions about their life that maybe aren't correct. When they're well and they're at home, a lot of work goes into keeping these children well. They have families who are devoted to them, who love them. They're often the center of a huge family circle that are all kind of there to support them. They get lots of lovely experiences like going to school, going on holidays, being around their brothers and sisters and their friends. So I avoid the quality of life kind of conversation. What I say is, the way I would put it is, I'm not sure our interventions are going to get your child back to where they were before, or I don't think our interventions will work. And I think it's more appropriate to make sure that the time they have is quality time rather than time spent with painful, unnecessary interventions. And it's to try and, I think we have to try and deburden the parents from the feeling of them being responsible for ending their child's life in these circumstances. It would be great to go into these things more, but I'm sort of I feel like I've raced through and covered a sort of a broad topic very quickly. So I'm gonna stop it there, and if there's any questions or any discussion points that anybody wants to talk about, it'd be very welcome.